Well, good morning to everyone and welcome to Medical Grand Rounds. We'll get started with a few logistics and reminders before getting into introductions for today's very special session. Again, thank you for your patience as we continue to adapt our schedule as needed this week and over the coming weeks. Just a couple quick updates. We are expecting our talk from Dr. Carolyn McCulley, which will be fever of unknown origin from a rheumatology perspective. Please stay tuned as to whether that will occur live or perhaps be available virtually next week. And for those of you interested, Dr. Schaefer's Thieves Market has currently been rescheduled to March 11th. Stay tuned. As a reminder, Grand Rounds is a joint effort between Providence St. Vincent and Providence Portland Medical Center. We are often available in person Tuesday mornings at 8 a.m. at Southern Auditorium at Providence St. Vincent, though that is currently on pause. And we are sometimes available live at noon at Providence Portland. We always make every effort to have Grand Rounds available live virtual on Teams Live. You can earn CME credit through any of those formats, being in the room, watching live virtual, or also by watching a recording of the event. And that recording is available at the same link as the weekly Grand Rounds invite. We will continue to keep you updated regarding the location of Grand Rounds. I'll be monitoring the Q&A throughout today's session, so please go ahead and post any questions or any comments, and I will mostly hold those as time permits at the end of today's talk. And now, I'm delighted to introduce this year's Dr. Gilbert Lipschitz Memorial Lecture. Dr. Lipschitz, an outstanding gastroenterologist, was known and admired by many of us. Gil had an enthusiasm and zest for life that carried over into his medical career. He listened keenly to colleagues and patients alike. He loved to teach, and he taught well, often and humanely. It is for his passion for medicine and teaching, and for his humanity that this lectureship was created in his honor. And what a tribute it is to this year be hosting Dr. Michelle DeThomas. Dr. DeThomas is currently the Assistant Deputy Medical Executive over Palliative and Complex Care with the California Correctional Healthcare Services, which strives to improve whole person care for those struggling with the challenges of serious illness and aging behind bars. Since 2007, she has served as Chief Physician and Hospice Medical Director at the California Medical Facility, which provides end-of-life care to men incarcerated in the California Department of Corrections. She earned her medical degree from the UCSF-UC Berkeley Joint Medical Program and completed her residency at the UCSF Department of Family and Community Medicine. As Hospice Medical Director, she works with the hospice team to create an environment where patients can live their final days with dignity, respect, and comfort, despite their incarceration. The hospice team supports the patients and their families in achieving compassionate release, and when this is not possible, provides a setting where they are able to have meaningful visits and often find reconciliation and closure at the end of life. Dr. DeThomas, we're so delighted to have you with us here in Portland. Thank you so much.
Oh, thank you so much for having me. So let me just set this up. Okay, so I just wanted to share a little bit about my pathway to the correctional setting. As you mentioned, I trained at the University of California, San Francisco, and in 2006, the courts determined in California that the medical care inside our prison system was unconstitutionally poor. And so we were put under a federal receivership. And at that time, they gave a large grant to UCSF, to the Department of Family and Community Medicine. And I went in initially as a consultant. But after working there for a period of time, I realized that there was a certain power you had from being inside and actually being the one looking at policies. And so I ended up taking a state job, and I've been there ever since. And so over the last, almost 20 years now, we've seen dramatic improvements in the care in our system. Every patient has a primary care provider. We have population management tools. They get hepatitis C treatment, medication-assisted therapy for opiate use disorder. But the one area that continues to pose a real challenge is caring for older adults in this setting. And so that's what we'll talk about today. I also want to just mention that some of the photos throughout this presentation are from Ron Levine. He has a beautiful book called Prisoners of Age. So the learning objectives for today, I hope that at the end you'll be able to explain challenges faced by those aging in an incarcerated setting, list the benefits of hospice and palliative care for incarcerated people, understand the barriers to reentry for older adults, and explain ways that community-based healthcare professionals can advocate for these patients. I would like to point out that the views and opinions expressed here are my own and do not necessarily reflect the views of the California Correctional Healthcare Services or the California Department of Corrections, and I have no financial disclosures. So just a brief overview. First, we'll look at some background data, then we'll discuss the needs of an aging population, pre-sentencing, during incarceration, and post-incarceration, and then finally consider how healthcare professionals' roles can be in addressing some of these challenges. So for the last decades, the United States has actually been the world's leading jailer. But over the last few years, our rates have come down a little bit, and 3 countries have exceeded us: El Salvador, Cuba, and Rwanda. So right now, our rates are about 614 per 100,000. Interestingly, my slide is for California at 494 per 100,000, so slightly less than the national average. But Oregon also is 494 per 100,000. So California and Oregon are the same. When we look at other countries that we would consider maybe culturally similar, Canada, we incarcerate 6 times more people than Canada. And when we look at countries in Scandinavia that have perhaps a slightly more progressive criminal justice system, we incarcerate 10 times more people per 100,000 than Norway, Denmark, Sweden, and countries like that. When we look at Oregon, you guys have about 22,000 people behind bars, the majority, 13,000 being in state prisons, and about 6,500 in local jails. And remember, people in local jails are often pre-trial. They have not yet been convicted of anything, or they stay there because they've received a short sentence, and so they don't transfer to state prison. The Pew Charitable Trust did sort of a classic report in 2008, and it found that 1 in 100 Americans were currently incarcerated. And over the past decades, the number has dropped a little bit, but we remain extremely high rates of incarceration. So this means approximately 1 in 30 men between the ages of 20 and 34 are currently incarcerated. 1 in 9 African American men between those ages is currently incarcerated. 1 in 100 African American women between 30 and 40. And remember, 60% of incarcerated women have children under the age of 18 that they've had to leave behind. The lifetime risk for an African American man in this country is 1 in 6 or 1 in 3 chance of being incarcerated. Some of the contributing factors, we not only incarcerate more people than most places, we give very, very long sentences. 1 in 10 people in the United States are sentenced to life. There are 3 strikes laws that even if your crimes were nonviolent, there are people who end up with a life sentence for committing 3 crimes. We have mandatory minimums, which means that a judge cannot use his discretion to consider mitigating circumstances such as developmental delay, post-traumatic stress, or mental illness. Many states have enhancements. So, for example, if I commit a second crime, because I had a first crime, I automatically get 5 additional years added onto the sentence. If I had a gun on my person but did not use it during a burglary, you can get 15 years added onto your sentence. So there's a number of ways that we end up putting people behind bars for a very long time. There are limited parole opportunities. We often have a lack of mental health, substance use treatment disorder, and geriatric care inside of these facilities, making getting out very challenging. And then there's, for reasons that we don't fully understand, but there's been increasing rates of conviction for older adults. It needs more research, but there's thought that it's related to the growing number of unsheltered older adults and inadequate community support for people with dementia. Just briefly, this is obviously an equity issue as well. The gray bar is the percentage of the total California population, and the blue bar is in CDCR. So you can see that while Black Californians make up about 7% of the population. They make up almost 30% of people in prison. This is also disproportionately high for Hispanics in the first column, and for the white citizen, they're underrepresented with fewer numbers than they are in the general population. This is Oregon. Obviously, your state demographics are a bit different. You have about 86% white citizens in your state, but we see the disparity as well among your African American population, with about it's about 1.6 of your state population, and yet it's about 11% of those behind bars. So the reasons for this disparity include, it happens at many levels, from who gets pulled over, who is detained and who is released, who is offered and able to make bail, who has those financial resources, who is charged or not charged, what they're charged with, whether it's the prosecutor who decides, is this manslaughter, is this second-degree murder, is this first-degree murder? And then there's very significant sentencing disparities by race. For example, for similar offense with a similar criminal background, a Black male will receive, on average, a 19.1% longer sentence than the white male with a similar situation. When we look at life without the possibility of parole for nonviolent offenses, 65.4% of those people are Black and only 17% are white. When we look at youth life sentences, so children sentenced to life in prison, 80% of those are children of color and 55% of those children are Black youth. And then, at least in California, we have about 40,000 lifers. I think I looked up Oregon. It looks like you all have about 1,000 lifers in Oregon, but 60% of those people are people of color. Not surprisingly, our patients also have an extremely high rate of adverse childhood experiences when compared to the general population. This is a study done by an organization that goes into facilities and works with a trauma-informed approach. So it wasn't a randomized control study, but it does ring true to my experience as well. When we look at people with 4 or more adverse childhood experiences, that occurs about 16% in the general community. When we look at people with 4 adverse childhood experiences in a prison setting, it's about 78% of our population. So our patients have caused harm, but they have also been harmed. So when you put a lot of people behind bars for a long period of time, you end up with a lot of incarcerated older adults. And so nationally, between 1993 and 2013, we saw a 400% increase in those over 55. In 2021, adults over 50 were 20% of the national prison population. And if these trends continue, it's estimated that by 2030, a third of the prison population will be over 50. In California, during my time with the department, I have seen the population get older. There's more gray hair, there's more cognitive impairment, there are more people with walkers and wheelchairs. In 2010, we had about 11,000 people out of 150,000. So a lot more incarcerated people in California at that time. And older adults were about 7% of the population. Now we have many fewer people overall, about 95,000. Our overall prison population has dropped significantly, but we have 19,000 people over 55, about 20% of the population now. So in the medical literature, I just want to mention, we tend to talk about people as 65 and older as being geriatric, but in the prison population, we tend to use 55. And this is because incarcerated people tend to have a chronic disease burden and a degree of functional impairment that's similar to people 10 to 15 years older in the community. This is primarily due to social determinants of health, both prior to and during incarceration, including violence, trauma, stress, substance use disorder, low socioeconomic status, etc. And when we look at people aging in a prison setting, there's some very unique challenges. We have Americans with Disability Act requirements as everywhere, but can you imagine being mobility impaired in a prison setting, or being hearing impaired, or going blind in this setting? Becoming incontinent when you live in an 8x6 cell with another person and now you have urinary and or fecal incontinence. You can be profoundly isolating for everyone, actually, but especially for older adults. People have to deal with serious illness and end-of-life care without being able to access their families. Cognitive impairment is extremely challenging. We have one patient who was banging on the door all the time. He was banging on the door, and you go and tell him. You'd say, "What's the matter?" He said, "My wife is going to pick me up in the parking lot, and I need you to open the door." And we'd explain that his wife wasn't coming today to pick him up, and he'd say, "Oh, okay." And then 10 minutes later, he'd start banging on the door again because he couldn't hold these thoughts in his head. This is also very difficult for staff. You know, we have good people quit, and others put up walls to protect themselves because this watching this can be really dehumanizing. For both staff and for the patients. So there's also, these patients are at risk of victimization. And as I mentioned, there's a lot of risk for moral injury to staff when you're not able to achieve proper care because of the setting in which you're working. So these pictures represent pretty common scenes in California prisons. Men and women with ADA needs are given these vests so that staff and others don't mistakenly think that someone who's violating a rule just because they can't see that they're walking into a prohibited area. So you would see, oh, that person's visually impaired. Perhaps they don't know where they are. The mobility vest, when we have an alarm go off, everybody's supposed to get to the floor immediately and then have to stand up. And sometimes people with mobility issues aren't able to do that in a timely manner. And then you can see here the gentleman who's mobility impaired is guiding the visually impaired person with the orientation cane. We see lots of people, walkers, wheelchairs. This scene is it's a dorm setting where a lot of older adults end up because they have equipment. They have CPAP machines, they have oxygen concentrators, they have walkers, wheelchairs, and their living space is very small. So that leaves very little space for personal property. So the purpose of this slide is just that many prisons are absolutely not what you imagine based on the media portrayals. So now I want to talk a little bit about pre-sentencing. I'll tell a story about a recent patient. She, before incarceration, had lived alone in a mobile home community. Her family had noted that she was declining cognitively, and she was also having some stress and disagreements with a neighbor. The family worked full time, they didn't have a lot of money, and they didn't have the ability to stay with her. They, not knowing what else to do, actually reached out to the police a couple times because they were concerned for her safety, but there were no services in the rural area where they were living. One day, soon after this, their mother came to believe that her neighbor was poisoning her dog. She went to the neighbor's house and she had a broom in her hands. There was a verbal altercation and she swung the broom. It hit the neighbor in the neck, collapsed her trachea, and she died. So this woman was then placed in prison, and over the next 8 years, we watched her dementia progress. She became bedbound, incontinent, incapable of any meaningful communication, and her family was devastated. Her daughter actually told me that she had never seen her be violent in her entire life. Quote, "Even when I was a terrible teenager." Ultimately, the day before she died, she was released under our compassionate release program to a community hospice where her family was able to be at the bedside for her last 24 hours. You know, I tell this story because I feel like the system failed everybody in this case. It failed the victim, it failed the victim's family, it failed my patient, and it failed her family. So how do we, what can we do to prevent this sort of scenario? First, I think we need to augment community supports for older adults and their families. We need to have services for people with cognitive impairment. We need to do education so families understand how they can support people with cognitive changes. We need more training for police, lawyers, judges, and parole officers so that they understand what they're encountering. There was a University of California, San Francisco Criminal Justice and Aging Project, and they interviewed police and judges and public defenders throughout San Francisco. And one public defender said about his client, his crime was to go to a coffee shop and steal the tip jar. He would always go back no matter what, even with a stay away order. Even though we would talk to him daily about not going, he would go back to the same coffee shop and steal the same tip jar. I think if we had been more educated in what was going on, dementia, we would have been able to do a better job. He's still out there floating around the system, in and out and in and out. A judge spoke about a 75-year-old woman who'd been arrested for abusing her elderly husband of many years, which was very out of character for him. She spent months in jail, and during the trial, she was diagnosed with a frontal lobe tumor that explained the bizarre change in her personality and behavior. Another lawyer shared a story that his team had actually been given a cognitive impairment training, and the case. And after that, they had a case where one of the clients was being tried for a very serious crime that was the result of his dementia. And instead of incarceration, this lawyer was able to have the patient conserved by the county and ended up being placed in an assisted living rather than being sent to prison. There's actually a study that looks at trainings for parole officers to prevent people from returning to prison. And in the Journal of the National Academy of Sciences in 2021, they published a study that showed a 30-minute online training for parole officers reduced recidivism rates by 13%, just by creating empathy and helping them understand some of the challenges that people face. The next thing, we need to grow links between police and community resources. In an interview with one police officer in San Francisco, they said, "We work 24/7 and our crises don't happen Monday to Friday, 8 to 5. At 2 a.m. on a Sunday morning, we get called about an old person. We can't tell if it's criminal activity or if there's a health issue. The remedies that are available to us in the moment are very limited. They can go to the hospital or they can go to jail." And then finally, this doesn't exist, but I like to propose it just to put the idea out there. But there's the idea of collaborative courts. They would be modeled after a collaborative courts that have proven success for people with mental health disorders, people with substance use disorders, veterans. And these are courts that bring in social services for this particular population. And it gives judges options and alternatives to prison. In Michigan, there was a mental health court that was designed in this fashion, and for every it saved $7 for every $1 that was spent, and it reduced recidivism by 300%. And I could imagine a setting where for older adults, we had the services, we were able to assess for cognitive impairment, we were able to understand the social context in which they've ended up in this situation. Just checking the time. Okay. So the next question is, how do we support these patients right now who are aging in prison and have growing challenges with cognitive impairment, serious life-limiting illness, and the very real challenge of dying in prison away from your families? In California, we've increased our trainings in geriatric and palliative care, and this includes custody. We want custody to understand the changes that come with aging and give them the tools they need so that they can respond appropriately. When an older adult isn't following instructions or they're not able to finish their meals quickly enough, we want that officer to be able to make a humane decision in how to handle that situation and not give somebody a rules violation. When we do see people who've been incarcerated for a long time who've not had any rules violations. And as they get older, they start getting them for refusing to go to work or not being in the right place at the right time, not doing things quickly enough. So we want to make sure that that doesn't happen, because then when that person goes before the parole board, they said, "Oh, you had a rules violation. You obviously aren't somebody that we're ready to let out." Programs, we have programs for older adults to help address isolation, giving them spaces where they can support each other, have peer support from younger men. We have increased our number of medical social workers to help with advanced care planning, identifying a surrogate decision maker, and reunifying families. And I'll talk about that more later. And then also developing reentry plans. When someone goes to a court or parole board and they don't have a reentry plan, that makes those entities much less likely to release them, worried that they will not have a safe landing place. And then we want to create normalized spaces for end-of-life care and memory care. And programs like these not only improve patient care, but they really improve staff satisfaction when we actually have the tools to do the right thing for our patients. So I'm going to now talk about a best practice. So in our system, we have a 17-bed inpatient hospice at the California Medical Facility, where I worked for about almost 20 years. This medical facility hospice was started in response to the HIV/AIDS epidemic by actually Dr. Elizabeth Kubler-Ross, who was the godmother of the hospice movement. And she heard about all of these men dying in the prison in California of HIV/AIDS with absolutely no one by them. They were dying alone in their cells because this was the 80s. The staff was actually still afraid, custodial staff and medical staff. Their peers were afraid of them. And they had really nobody. So her and her team of volunteers went in and started doing groups with the population, giving them some support. This developed into a 17-bed inpatient hospice through collaboration between incarcerated men, the legislation, people within CDCR. And in 1995, there were 56 HIV deaths in that hospice. When I started in 2006, we had nobody dying of HIV, but those people have been replaced by older adults dying of things that older adults die from. So we have 60 to 70 people die in our hospice each year. It's run consistent with community standards, and it allows for dignity at the end of life for the patient, their family, and for staff. It's nothing, honestly, it's nothing special when you walk in other than it doesn't feel like prison. It feels normal. It feels like a nursing home. There's no locks or bars. Our patients can interact with staff, with the peer supports, and with each other freely. Security is maintained not with handcuffs and bars, but with this concept of dynamic security. Through mutual respect, we get to know each other. We understand their anxieties. And we can address problems that may arise before they lead to conflict and security risk. And we've done this for decades with success. We never have incidents. And these are the same people who were living in a prison before they got their diagnosis and possibly getting in trouble. But in our setting, it creates a really different expectation, and people can live up to that expectation if you set it for them. This is a picture of just this typical room. I like this picture because it shows, we do have bars on the windows, but these blinds make it feel more comfortable. In prison, you have this sort of metal steel toilet sink combo thing. And in hospice, we actually have porcelain toilet and sink, and that may not seem like much to you, but it really makes it feel different. We have quilts from some local community churches that they donate. This is a beautiful garden. It took us about 15 years to get, but we ended up getting funded by the California Healthcare Foundation. And we can bring our patients, we can bring their whole bed out here to sit in the garden. Family is allowed to visit here. We've had weddings, baptisms, memorial services in this space. We recently, I can think of a patient that we recently transferred who had dementia. He'd been housed alone in a cell at a medical unit in another facility for years, basically spent all his life in this one room. And when staff would come in, he would often yell at them to get out. He would get very agitated. Sometimes he even incurred rules violations for his language, and he had very few possessions in his room. He developed prostate cancer, and we ended up transferring him to hospice. And when we brought him out to this hospice garden, he could see trees, flowers. We have hummingbirds and butterflies. He was able to smell mint and rosemary and lavender. These simple things that we take for granted were truly mind-blowing for this man. He had tears running down his face. He had a huge smile. He kept saying that this was delightful. He really opened up. He had serious cognitive impairment, but a lot of his behavior and his closed down persona was because of depression. And after we were able to connect with him, we actually found his 3 daughters who hadn't spoken to him in years, and they were able to have video visits and really grateful to reconnect before he passed away. He was a great singer. He couldn't remember anything from 5 minutes ago, but he could remember all the words to every song from the 1950s, and loved having a good song with our social worker. A big part of the program is also to support people spiritually, no matter what that spiritual connection may be for them. Our chaplain is Protestant, but he goes out of his way to support people in whatever their religion is. This patient had a strong Eastern religious philosophy. We had a Vietnamese patient whose mother had been visiting him. He was very young, he was in his 30s. And when he died, his mother was devastated because she believed that his soul would stay in the prison for eternity unless we did a ceremony to release it. And normally family would not come back into a prison after somebody died. But we got permission from the warden, and we got a Thai Buddhist monk volunteer to come in, and the woman and the monk came in and they brought a flower, a candle, and a cookie, I think. And they we were able to clear the room, and they performed this ceremony in the room where her son had died so that his spirit could be released from prison. So it can be challenging to care for the family. You know, the real part of the hospice mission is to care not only for the patient, but the family. But we can do it, and we really make efforts to do things like that. This was one of our Native American patients. We have a Native American spiritual leader. They do smudge ceremonies. We have a sweat lodge. Most of our patients are too sick to sit in a sweat lodge, but some of them have gone out and spent a brief minute out there as part of their end of life goals. We have recreational therapy. They do art. We do legacy building, where the social workers or the recreational therapists will help the patient. You know, our patients are not just people who've committed a terrible crime, but they're often people who had wonderful successes in life. They raised children, they were mechanics, they were in the military, they were decorated war veterans. And so how do we help that person focus on some of the things that gave meaning to their life and not just focus on the fact that they are dying in prison? We also have a memory care unit that focuses more on the needs of people with dementia. And, you know, we have a special training for the staff that work in this space, and it really needs to be multidisciplinary. The nurses and the custody officers really need to be connected in this work. A potentially volatile situation can really be diffused if an officer understands that someone is cognitively impaired and that this behavior is not coming from belligerence, but from a place of anxiety. We have one patient who, you know, he gets upset, but the officers know that he's always looking forward to a visit from Angeline, our Pause for Life companion pet, who comes to the unit multiple days a week. And so if he starts getting upset or agitated or refusing to go to the shower, the officers know. They just start talking about Angeline, and it completely changes. He starts talking about her, he talks about his childhood pet, and he's much calmer and able to redirect. We have a contact sheet for each of our patients, just to make sure there's nothing that's going to get them in trouble. So for example, we had one patient who was a boxer in his youth in Cuba. And when you go to greet him, he often puts up his fists and starts kind of just play fighting with you. But if you didn't understand this about him, you might think that that was an aggressive, belated stance, and he could get himself in trouble. But we have a book, so any new staff on the unit can see, oh, this is something he does. All you have to do is greet him, and there's really no problem there. One of the best parts about both of these programs is our peer support workers. These men are extensively trained to provide care for their peers. In May of 2018, Suleika Jawad is a writer and was working with the New York Times, and she came and spent 2 weeks in our hospice. She came in thinking she was going to write about the patients, but what she found most compelling was the 3 young men who were working in the hospice. They worked side by side with medical staff to care for the sick and dying. They had all committed violent gang-related crimes when they were 17, 18, 19, and now they're in their 30s and 40s and want to give back. They're different people now. And so this program benefits the patients, the peer workers, and the staff. These peers are able to connect and support the patients on a really deep level. The bonds that they build in a very short period of time are inspiring. They're all separated from their families, and most of these men are lifers. And so they all have this universal fear of dying in prison. It's a powerful experience for the workers themselves. It gives meaning to their life. It teaches empathy, skills, self-worth. All 3 of the men who are featured in that article had life sentences, but they've managed to convince the parole board that they were rehabilitated, and they're all doing great work in the community now. And then they provide the support to staff. They contribute to a really high quality care and definitely improve staff morale. We really love working with these guys. One of our peer volunteers said, when I first joined the hospice program, I didn't fully understand who we were going to help. I didn't realize how many people in the prison were dying. I originally joined the program because I saw it as a way to atone for things I've done, but I've learned a lot more about myself in the past year. I have found abilities and strengths I didn't know I had. And I love this picture because you know, the picture of there's a, it looks like a rabbit or a duck, depending on how you visualize it, an optical illusion. This picture makes me think it could be, this could be a picture of a young man getting counsel from an older man, or it could be an older man getting support from a younger man. And in reality, it tends to be both ways. One final aspect of this program that I really love is that the culture in the hospice tends to expand out through the rest of the facility. We had a patient who was probably in the last 2 weeks of his life. He really wanted to say goodbye to his daughter, who was also incarcerated at a women's facility in Southern California and struggled with mental health problems. So she was in a psychiatric administrative segregation unit. So people within a prison don't usually get to talk to each other through different facilities, but our warden, we pushed and he agreed. And he said he'd have to ask the warden at the women's facility. So he reached out to that warden who also agreed. He assigned it to a captain who arranged for her mental health team there to be there to support her after the phone call. The man and his daughter had a 15-minute call. They were tearful. They were able to say goodbye and have some closure before he passed on. We were grateful that our patient got to have this. But the best part of this was about a week later, we got an email from the captain who had facilitated this at the other facility. And he said in 20 years of service, this was the most rewarding thing he had done. So it's one person who's, you know, potentially in a leadership position going forward, who realizes that you can honor people's humanity and still have safety and security. These don't have to be mutually exclusive. And then the last thing about hospice is, you know, we really do try to bring family in. This wreath was a gift from a family who was so grateful they were able to spend time with their loved one before he passed. And our chaplain does an incredible job of reuniting families. He has a story where the patient had been living, he'd been unsheltered, he had mental illness, he'd been living on the streets of San Francisco for decades before he came into our system and completely lost track of his family. And he knew his childhood address, but none of the phone numbers worked. And so the chaplain looked at this address on Google Street View and then swung the camera around, and there was a church across the street. And so he zoomed in on the sign, he called the church, and they actually knew the family, and they had moved about 5 blocks away. So the church sent somebody out to find the family, let them know where their son was, who they called the chaplain, and this mother and father were able to come into the facility and see their child before he died. We have another story of 3 women. Their father had been very, very abusive, and it actually killed their mother in a drunken rage when they were like 6, 7, and 8. And he had been a monster in their mind their entire life. They grew up with other relatives and they had never seen him. And now they're in their 30s and 40s, and he's a very diminished man in a wheelchair dying of lung cancer. The chaplain reached out to them carefully because we don't want to re-traumatize, just to let them know that he was there. They said they did not want to see him. And then after they talked, they called back and said, you know, we actually think we do need to see him. And so we were able to bring them in, and in a supportive setting, they were able to speak with him and, you know, forgive him, not necessarily forgive him, but at least give him a feeling that he was heard and his apology was heard. And so in the end, he died with that piece. But the 3 women, these 3 sisters, got to live the rest of their life without this monster on their back. They were able to have closure as well, and we're extremely grateful for that. So, you know, although we have managed to create an environment inside of the prison where people are getting high quality end-of-life care, the reality is no matter how good that care may be, our patients universally nearly universally have an end-of-life goal to not die in prison. And so a significant aspect of our work as palliative care healthcare providers in this setting is to provide the patients assistance in hopefully achieving their freedom. Not only are there ethical reasons for supporting this perspective for people who have been punished and people who are rehabilitated, but there are public safety and fiscal arguments for reducing the number of older adults. There's a report called The High Cost of Low Risk put out by a group in New York, and they found older adults cost 3 to 5 times more than their younger counterparts. They incur the majority of offsite hospital costs. They require infrastructure upgrades. We have to have elevators. We have to have level terrain. We have to have the ability to have ramps. All of this is very fiscally untenable in many cases. These people also have very low recidivism rates. So for California, people who had life sentences who were released in California, less than 4% commit a crime, and that's including misdemeanors. And if you look at people who do a serious crime that incurs harm against another, it's less than 0.4%. So we're paying a lot of money for people who are very low risk. Some of the barriers to release. There's not a great pathway for us to communicate medical frailty to the decision makers, meaning the court or the parole board. So how do we build bridges between the medical providers who see these patients 24/7 every day and the people who are making decisions about release? There's limited supportive housing options for release and reentry. There's a lot of societal challenges that face all older adults in our country, not just people coming out of prison. There's a lack of affordable housing, and there's a growing homeless problem among older adults. We also have a lack of social support networks for the aging. And then there's the added challenges for our patients. They've lost community connections. Many of them are, they're in their 80s. All of their family has passed on. They really have nobody out there. And there's the stigma of incarceration, meaning that many facilities don't want to accept our patients. So, what's the role of healthcare in this? Even for people working in the community, there's a group in Washington, D.C. called Medical Justice Alliance, in which community doctors provide summaries of patients with complex medical needs to releasing authorities. So they review the chart, they create a summary, and they present that information objectively to parole boards, to courts, to public defenders and district attorneys, just so that this information can be used to create a more complete picture of the person. They need to know that people have dementia that make them unable to have any executive function. They need to know if somebody has a very poor prognosis and this may be their last chance at a parole board grant. We need to develop more reentry programs. There's a lot of reentry programs for people with substance use disorder, people with mental illness, even some, historically for people with HIV. So a model exists, but we need to have reentry programs that focus on the needs of the older adults. My patients don't need to learn job interviewing skills. They need to learn how to navigate a medical system. They need to get connected with their Social Security. They need to be reconnected to family. We need to build relationships with SNFs and nursing assisted living facilities that are willing to overcome the stigma of incarceration. If a person killed somebody 40 years ago, 99% of the time, they are a completely different person now. And, the person in this picture gave permission to share his photo because he wants to use it to help others have the opportunity that he had. So we were trying to get him placed. He qualified for compassionate release, but we were having no luck getting a nursing home to accept him. He had end-stage pulmonary disease. We finally got one nursing home to say, fine, we'll take this one patient of yours, but we're not taking anybody else for at least a year. We sent him out. He had lovely family, but they all worked full time. They struggled socioeconomically. They couldn't take time off work and they didn't have space in their home to care for him. And they lived on a second story with no wheelchair accessibility. So he went to this nursing home, but his family really gathered around him. They brought him his favorite meals. They told stories and he died a week later. The nursing home called me back though, and they said, he just passed. We're so sorry. This was an incredible experience for our staff to be able to support this family. and we have a bed open and we'll take another one of your patients. So, you know, the people that we are trying to send to the nursing homes are not the people that they're anticipating, and helping them see that can make a big difference. We need to expand the work of medical social workers in jails and prisons, and we need to do more work around supporting and expanding compassionate release. And medical expertise should be involved in justice-involved policy and legislative change. When we don't have doctors involved in these decisions, the legislation is not as good as it could be when we have a seat at the table. So this concept of compassionate release, this exists in every state and the District of Columbia, but it's underutilized. In California, we were actually able to get to the table with justice-involved organizations, medical people, and create some legislation that really streamlined and expanded our process in the last 3 years. Our patients are required to have an end-of-life trajectory. It used to be 6 months, and then it was 12 months, but doctors aren't great at prognosticating. We tend to overestimate by a factor of 3 how long people have. We're an optimistic group of people. So by changing the phrasing to an end-of-life trajectory, we were able to have doctors kind of overcome their fear of like, well, if I say he's going to die in 6 months and he doesn't, this way I know this man has metastatic lung cancer. He's going to die in the next few years. And so that gave us some flexibility. Also, people can be permanently medically incapacitated. So if you had a massive stroke and now you're bedbound and unable to care for yourself, you can qualify. We've developed tracking tools that allow us to monitor to make sure people don't get stuck on somebody's desk and don't move forward and then die. We've done trainings with our doctors on prognostication, and they do a much better job now of identifying people. The patient in this picture, he's a 90-year-old veteran who had end-stage pulmonary disease. And before the change, the doctors weren't comfortable saying he had less than 6 months. We just didn't know. But for a 90-year-old oxygen-dependent patient with his degree of lung dysfunction, we could easily say he's on an end-of-life trajectory. And so his nephew was able to, he was granted release. His nephew picked him up, flew him back to Maryland, where he was put in a veterans home and was able to be celebrated for his honorable work in the military before he died. One of the biggest challenges is coming up with a post-release plan, as I mentioned. There's also benefits to the family. We had another patient. He had a 13-year-old daughter that lived in the community where the prison was, but he wasn't able to be with her. He held on till the very end. He was granted compassionate release. He went out and he was able to spend his last 3 weeks with his brother-in-law, his sister, and his 13-year-old daughter. They watched all of her favorite movies together. She was able to support him at the end of his life. And to me, the most important part is that 13-year-old child won't have a narrative that her father died in prison. Her narrative will be that she was able to support her father at the end of his life. And then, as I've mentioned, there's benefits to staff morale. We had a patient a couple of months ago who he had developmental delay. He was, probably 60, but he functioned at the level of about a 10-year-old cognitively. He had been incarcerated for about 27 years. And he had 3 sisters who desperately wanted him to return home. He and his brother had both been incarcerated together since their 20s. They were involved in the same crime, and the brother had died of COVID about 2 years ago. So the sisters, when he was able to be released, their joy and gratitude was a huge boost for our hospice staff. It really helped them, help the entire team. So for Oregon, the FAM is a Washington, D.C. based organization that advocates for medical releases nationwide. And they actually have a website that lists the criteria for every state, because it's a little different for every state, and gives the step-by-step requirements on their website. So if you go to this link here, you can pull it up for Oregon and see what the criteria are for your state. So some practical tips. I really hope that this discussion has grown your understanding of this vulnerable and often unacknowledged population. So if you're working in a clinic, and you have people maybe come into your clinic who've just gotten out of prison or jails. There are reentry supports in your community. Find out what they are so that you can give them access to these resources. Many organizations have people with lived experience, meaning people who were formerly incarcerated who now work for their organizations. They've gone through this challenging reentry process, and they'll be assigned as a case manager to help your patient navigate the system. If you work in a specialty clinic, we call them forensic clinics, but it's basically a specialty clinic in the community. If you have a patient, maybe you're an oncologist and you have a patient who may be at the end of life, understand your state's compassionate release recommendations and send something in your progress note. This patient may qualify for compassionate release or medical parole. Speak to the doctor, the head doctor at the facility where this patient came from, to make sure that they understand the rules around compassionate release or medical parole. You can be your patient's advocate. In the emergency room, remember that your patients have decision-making autonomy. They've lost their physical freedom, or their physical liberty, but they retain their rights over their medical decision-making. Communicate with the institution medical team. The patient's going to show up with an officer. That officer has no idea about their medical situation. And if you don't have that information available to you, reach out, ask the officers, what is the number for your chief medical officer? I need to speak to them. I need to get medical records. I put a website here, it's called Scopes and Shields, and it's a group of critical care pulmonologists who work in the community who wanted to be able to share our patients' rights, incarcerated patients' rights, when they are in a community hospital. So there's a lot of great information there. If you work in a hospital, remember that your patients, they should be treated ethically, the same as any other patient in the community. I don't make decisions for my patients. If they aren't able to communicate and they don't have a defined surrogate, you can pull them into your ethics committee for your hospital and treat them the way you would anybody else. They also have the right to family contact for serious illness. So don't let your patient die alone. Reach out again to the facility and find out, how do we create a pathway for this person's family to be at the bedside when he's dying? If you work in a skilled nursing facility, accept our patients. Advocate for acceptance and try to counter some of the bias. And then if you're doing research or working in policy, include our patients, include people who have re-entered society, include their families, include advocates, including people who work on the inside. There are many people on the inside who are truly advocates for this population. And then finally, that's my contact information if you have any questions, and a few other resources if you want to learn more about our program. And if there's any questions, I'm happy to take them.
Dr. DeThomas, thank you so much for your profound work and this truly inspiring presentation. I think all of us are digesting a little bit as we pause and come up with comments and questions. I have several, perhaps I'll open with one. I think about the importance of trust in the healthcare system in general, often dependent on relationship. I can imagine even additional challenges for that in your setting. I'm curious if you have any comments on building trust, maybe particularly in the context of advanced care planning. Do you have practices that have been successful?
Yeah, it's a great question. I mean, not only are there reasons that there may be barriers, but there's historical reasons, that our patients don't trust health based on racial discrimination in society and medical staff, based on the poor healthcare that some of these men have been around for 20, 30, 40 years. They've seen bad healthcare in our system. So you do. And I've actually been asked to do a training for all new providers that come on into our system. And one of the things we talk about is how your patients aren't going to trust you. And there's good reasons why. And how do you build that trust? And honestly, I find that having a frank, making eye contact, letting them know you care, taking a trauma-informed history where you actually ask about you know, what brought you here? What were you doing in the community? Who do you miss? What are things that inspire you? Just from the very start, that's new for them. And to realize that there's somebody who actually wants to know these things about them. Just by those simple questions at the beginning, my patients would come in with pictures of their kids' graduation or picture of the soccer trophy because they knew that I actually cared. Our patients are extremely savvy. They're very good at reading who is being straight with them or not. And so I think just showing mutual respect and showing that you care goes a long way. There's something called overfamiliarity, and we're taught that it's us and them, and that they'll use anything that you give them against you. And we were even taught by custody when I started, don't share your favorite football team or they'll use it against you. I mean, that's absurd. Like with anybody, we need to build rapport. I don't share about my children necessarily, but I do want to hear about their children.
Thank you so much. Just to follow up to that, can you comment a little bit about who the healthcare providers are working in your system? Are these folks employed by the correctional system? A little bit of information and curiosity around that.
Yeah, so, you know, some states are different. Like I think Texas goes through a university system that provides the care inside their carceral system. In California, we are hired by the Department of Corrections, but because of the federal receivership, we're in a separate branch. We're in the California Correctional Healthcare Services. But you know, I think historically, and part of the reason we are under a receivership is because people saw this as a last resort. They've had challenges with their medical license. They maybe have their own substance use challenges or mental health issues. They weren't board certified. There were reasons people came to corrections historically that weren't ideal. But with the receivership, they doubled the salary. They required you have to be board certified in family medicine or internal medicine. It's completely transformed our system. And we actually recruit people who are socially justice minded, who want to do this work because they believe that everybody has a right to healthcare. And certainly that's not all of our staff. But the culture of the staff has changed over time.
Thank you. Just a couple of comments I'm pulling out from our audience here. Just thanking you. This is a huge portion of our community experiencing a profound social determinant of health that is essentially hidden. Here a comment and follow-up question. What an amazing care people who are incarcerated get in this system. How does this care compare with other places globally, like in Cuba, Europe, China, South America? Any comments on sort of the global landscape for healthcare in the prison system?
So, I mean, I think, you know, California tends to be on the cutting edge of this. I think even other states, like I wouldn't want to be incarcerated in Louisiana getting healthcare. So, and then globally, I'm not a global expert, but, you know, I was a Peace Corps volunteer in Malawi in East Africa. And, you know, the prisons there, like there were so many people in one room, they almost couldn't find a spot to lie on the floor. That was, you know, 30 years ago, but I doubt that it's a lovely place now. I remember the women in the village would have to bring the food to the prisoners or they wouldn't get food. So I think globally it's probably very, very challenging.
Yeah. What is the role of nurse practitioners in California specifically in the correctional system?
Yeah, we hire both nurse practitioners and physician assistants. They often serve as primary care providers under the supervision of, I think the PAs have to have an actual supervisor, and the nurses, we provide supervision and, you know, support for them as well.
Yeah. Great, thank you. Really appreciated towards the end of your talk, just some pragmatic tips. Many of us, perhaps one of the only time we interface with these patients is when they're admitted to the hospital. So thank you for a couple of those points. Real take home felt like the importance and opportunity of reaching out to the team at the prison. Any last follow-up comments that you want to make just about that particular interaction, things we should be aware of as people come into our hospitals in the community?
You know, one thing I find is the officer at the level that's sitting at the door, you know, he's not a decision maker. He's following policy. And, you know, these prison systems are sort of militaristic. So there's a reason for policy. I mean, you follow policy to make sure everybody's safe. But there are times where policy obviously wasn't intended for the dying man. And so when that officer says, no, he can't have family, don't take that as a no. Take that as the person that's at the door doesn't have the decision-making power to make an exception. So politely ask if he has a supervisor that maybe we could reach out to because this is an exceptional circumstance. Ask him if there's who's the chief medical officer at your facility? Could I speak with them? Because there's a situation here that I think doesn't necessarily apply. So be respectful, but don't take no for an answer. And most of the officers I work with, I'll say, I understand you can't make this decision. Would it be okay if I spoke with your supervisor? So it's not like I'm tattling, and I'm not doing it from a place of conflict. I'm doing it as that I understand you have to follow the rules, but I don't want to follow the rules in this case.
Great, thank you so much. Certainly, it's clear from your presentation you are willing and able to go far beyond the rules and what is best for these people. What an inspiring presentation. We have arrived at the top of the hour. Thank you so much, Dr. DeThomas.
Thank you for having me.